AP projection method. When hyperextension of the wrist is not contraindicated, this method is the best projection to provide a clear image of the first central metacarpal joint than the standard AP projection as Berman stated. The image receptor that we're going to use is 8 by 10 inches and the position is lengthwise by 90 degrees. The source of image distance is 18 inches to create a greater field of view. The patient position is the patient should sit at the end of the radiographic table so that the forearm can be adjusted approximately. So let's go to the procedure. PA projection folio method demonstrates sprain or tearing of ulnar collateral ligament of thumb at the MCP point as a result of acute hyperextension of thumb. The image receptor that is going to use is 8 by 10 inches crosswise at 45 degrees. AP projection Robert method. This method demonstrates the carpometacarpal joint of the thumb using This method uses a tabletop technique that requires patients to place their hand in a complex position. The image receptor that are we going to use is 8 by 10 inches. Patient position is the patient sit parallel at the end of the table with hand and arm fully extended. PA hand projection. A normal X-ray examination of hand will be demonstrated fractures, dislocations, or foreign bodies of the phalanges, metacarpals, and all joints of the hand. The image receptor that we going to use is 10 by 12 inches lengthwise. Patient position, sit patient at the end of the table with elbow flexed about 90 degrees and hand and forearm resting off the table. PA oblique lateral rotation. It is a fracture distal radius ulna or isolated fractures of radial styloid processes. Image receptor is 8 by 10 inches, division in half crosswise. Patient position is sit patient at the end of the table with elbow flexed 90 degrees. Go. AP oblique medial rotation. Location and extent of fracture and fragments, alignments, joint space, abnormalities, soft tissue, effusions, and location of opaque foreign bodies are demonstrated. The IR size that are we going to use is 10 by 12 inches lengthwise. Patient position, take radiograph with patient, supine or sitting, flex knee with plantar surface of foot on table. Lateral projection extension. Alternative to the fan lateral for localization of foreign bodies of the hand and fingers. Image receptor size is 8 by 10 inches lengthwise. Patient position. Sit patient at the end of the table with elbow flex about 90 degrees and forearm resting. Go. Wrist AP and lateral is requested for myriad reasons including but not limited to trauma, suspected infective processes, injuries, the distal radius, and ulna. Patient position is seated alongside the table and the affected arm is flexed at 90 degrees. So the arm and wrist can rest on the table in forearm AP and lateral. This view allows for the assessment of suspected dislocations or fractures and localizing foreign bodies within the forearm. The image receptor that are we going to use is 10 by 12 inches. Patient is seated alongside the table. Elbow is flexed to 90 degrees and medial aspect of the wrist. Forearm and elbow joint are placed in contact with the detector. Elbow AP and lateral demonstrates the elbow joint in its natural anatomical position, allowing for adequate radiographic examination of the articulations of elbow, including the humeral and humero-ulnar joints. Image receptor is 8 by 10 inches. Patient position. Patient is seated alongside the table. The full extended forearm in a supinated position are kept in contact with the table by lowering the shoulder joint to the level of the table. Radial head for position series. Place the image receptor in position and cover the unused section with a sheet of lead mask for the entire radial head, free of superimposition, for projection with varying positions of the hand and are performed. Image receptor is 8 by 10 inches single projection or 10 by 12 inches in 2-in-1 projection. Patient position is let the patient sit low enough to place the entire arm at the same horizontal. Distal humerus and acute flexion. This is a modified projection for the patients who are unable to straighten their arm due to pain. It's often conducted in the context of suspected supracondylar fractures in younger patients. However, it can be utilized in acute elbow imaging the following trauma. Image receptor is 8 by 10 inches. Patient position. Patient is seated alongside the table. The distal humerus is placed on the IR with the arm remaining in flexion. Arm is supported by a sponge. Hand is supinated.
Easy, reppin' for the set on the 1 or 2. Easy, hit the flip a check, homie, who are you?
Proximal forearm, partial and acute flexion. This is a projection for the patients who are unable to straighten their arm due to pain. Image receptor is 8 by 10 inches. Patient position is let the patient sit at the end of the radiographic table with the elbow Scaphoid long and Rafford method. This method describes the diagnosing scaphoid fractures using a 4-image multi-angle central ray series. This series is performed after routine wrist radiograph do not identify a fracture. Image receptor is 8 by 10 inches crosswise for 2 images. Central ray is 0, 10, 20, and 30 degrees cephalad. Patient position is let the patient at the end of the radiographic table with the angle and forearm resting on the table. Humerus, AP, and lateral. This projection demonstrates the humerus in the lateral position, allowing for adequate radiographic examination of the entire humerus and its respected articulations. Image receptor is 14 by 17 inches. Patient position. Patient is preferably erect. Patient is stand facing the detector with the injured side closest to the detector. Patient is then rotated so that the lateral aspect of the shoulder of the affected side, the arm of the elbow, and all in contract. Elbow is flexed 90 degrees.